Welcome to this webinar on autonomic nervous system testing using an EMG system. We use routinely the electromyograph to study diseases of nerves and muscles. Most often, we work with the peripheral nervous system, which contains the nerves in our limbs, the muscles, etc. And the diseases of the peripheral nervous system are often called neuropathy when the primary lesion is in the nerve or the neuron, or it's called myopathy if the primary disease is in the muscle. And the techniques to study these diseases are the nerve conduction studies in the motor fibers, in the sensory fibers, late responses, etc., and the needle electromyographic examination. Sometimes we study the diseases affecting the central nervous system. For example, multiple sclerosis or various types of movement disorders, dystonias, and so forth. And to study these diseases, we rely on techniques such as evoked potentials and tremor analysis. This is the way most often we use the electrodiagnostic system to study diseases of nerves and muscle. But besides the peripheral and central nervous system, there is additional component to the nervous system, and that is called the autonomic nervous system. The autonomic nervous system is a part of the peripheral nervous system and a little bit more. It provides innervation to smooth muscles, such as those that support the intestines, and they also innervate glands, for example, the salivary glands in the mouth. The primary objective of the autonomic system is self-government or maintaining homeostasis. So the autonomic nervous system is working in the background. We don't have to think about it. It does its job automatically in various areas, for example, in maintaining proper circulation, respiratory function, digestion, temperature regulation, Sudomotor, or the sweating, which is also related to the temperature control, the sexual function, etc. So all of these systems are continuously being governed and maintained by autonomic nervous system. Usually when we think about the diseases, we think about the central or peripheral nervous system. But keep in mind that the centers and pathways of the autonomic nervous systems include brain, brainstem, spinal cord, and the peripheral nervous system. So the autonomic nervous system can be affected in many instances. For example, it could be compromised in polyneuropathies. A common example of polyneuropathy is in patients with diabetes, or patients who have Guillain-Barré syndrome or other conditions may also have abnormal autonomic nervous system function. We can have pathology in stroke. ANS could be abnormal in multiple sclerosis. So there is indeed a wide range of diseases where the autonomic function could be abnormal. In our routine EMG nerve conduction studies, we usually don't think about testing the autonomic nervous system. But it does have a significant importance in our electrodiagnostic testing. As I just stated, ANS is affected in many neurologic conditions that we also test using the electromyograph. Now, the autonomic nervous system can be studied using dedicated equipment, but there are certain functions that can also be assessed by using an electromyograph. And the nice thing is, these procedures are simple, they are fast and efficient, and they provide us with immediate results. So, let's look at how we can use an electromyograph to study the function of autonomic nervous system. But before we do so, let's understand a little bit about the anatomy and physiology of this nervous system. The autonomic nervous system has two types of outputs. One is called the sympathetic and the other is called parasympathetic. The sympathetic output refers to the nerve potentials that are sent to the peripheral organs and glands. The sympathetic output is prominent when there is a threat. You suddenly become alert, or there is a threat to your life. That's when the sympathetic system kicks into high gear. The sympathetic fibers are derived mainly from the cranial nerves and the sacral roots. For example, your pupils will dilate because of sympathetic input to the eyes, and that comes through the cranial nerve number 3, which is also called the oculomotor. So by dilating the pupils, we are making sure our vision is not compromised in any way. There would be increase in the heart rate, there will be increase in circulation, and that comes through the cranial nerve 10, which is also called the vagus nerve. I emphasize the term vagus because when we select our test protocols in the EDX system, you will need to look for the vagus nerve. Now let's look at the parasympathetic. It is opposite to the sympathetic. It kicks in when we are trying to relax. The parasympathetic fibers originate in the thoracic and lumbar area. So with the parasympathetic drive, pupils will be constricted, your heart rate will become less, your circulation will become less. So in this sense, it is kind of inhibiting all of these functions. But keep in mind, parasympathetic does not mean that it is inhibitory. When the parasympathetic function becomes prominent, your digestion also becomes more important. That is accelerated. If you are in a sympathetic situation, you really don't want your body energy and blood flow and other things going to digestion. You want it for muscle activity. So with the parasympathetic input, digestion is enhanced. But with the sympathetic input, digestion is inhibited. So sometimes we try to make a mistake, like parasympathetic is inhibitory. No, it's not inhibitory all the time. It is inhibitory in certain organs, but excitatory in other organs. So let's not make the mistake of making them excitatory and inhibitory systems as such. Okay. Now there is a third part to the autonomic nervous system, which is called the enteric nervous system. It is related to the gastrointestinal system, and usually we don't talk about it. So we are going to focus mainly on the sympathetic and the parasympathetic nervous system. Here is a summary of autonomic nervous system. This is an illustration I have obtained from internet, specifically the Wikimedia. And it illustrates the structure very nicely. On the left hand over here, we have the spinal cord and the brain. Here is the medulla and here is the midbrain. And you can see in the blue color the different cranial nerves that are coming out over here. And here are the spinal nerves in the sacral section. And notice that this is the parasympathetic innervation, which is going to the intestines, kidneys, and sexual organs. Over here, it is going to the eyes, heart, and other things. So the autonomic nervous system is actually controlling a lot of vital functions and organs. If you look at the sympathetic system, those fibers are shown in red colors. Once again, they exit through the thoracic and the lumbar area. And then they go into this chain of ganglions, which is outside the spinal cord. And then we get the sympathetic output, which is also going to the various end organs. So the sympathetic and parasympathetic inputs to an organ will maintain its function properly. So let's talk a little bit about the routine nerve conduction studies. The routine nerve conduction studies assess the function of large fibers, large nerve fibers. And what do we mean by large nerve fibers? They have a diameter of 6 to 20 micrometers and they are myelinated. Myelination is a fatty tissue around the nerve fiber, which allows it to conduct the action potential at a fast rate. Because of the large diameter, these nerve fibers also generate more voltage proportionally. And as I indicated, because of myelin, they can conduct faster, and the conduction velocity is 30 to 70 meters per second. These are the fibers that we study in routine motor and sensory nerve conduction studies. But these are not the fibers that are affected in autonomic nervous system disease. These are the small fibers. One group of them is called the C fibers. They are responsible mainly for communicating pain. These are unmyelinated. They are small. Their diameter is only 2 micrometers. And they conduct action potentials at a slow speed, 0.5 to 2 meters per second. Then there is another class of fibers which is called the A delta fibers. They are slightly myelinated. They are a little bit bigger, about 3 to 7 micrometer, and they conduct action potentials from 3 to 30 meters per second. So why can't we study the function of these fibers? After all, we can stimulate them and we can record their action potentials and so forth. Well, there are some practical issues. Potentials from small fibers cannot be seen easily because of their low amplitude. The electrical current generated by a nerve fiber depends upon its size. A large fiber will produce more electrical activity. A small fiber will produce less electrical activity. And when we stimulate, we are stimulating large and small fibers at the same time. And the large fibers make a lot of electricity. And in their presence, we really cannot detect the activity from the small fibers. So that's one of the problems. So we have tried to get around that problem by using something called near needle recording or the near nerve needle recording. The phrase nerve is missing in this slide. So instead of recording from the surface, we can put a needle, bring it very close to the nerve fibers, so perhaps we can pick up their activity much more effectively. But even then, we have to stimulate the nerve many times, average hundreds of responses, and so forth. So it's not a very suitable method to study these fibers. So this is the way it can be done, and it has been done, but it's not a popular method. It's mainly in the research domain. This is the way we can look at the conduction in these small fibers. There is another method which is looking at the number of impulses and how they are sent from the end organs to the central nervous system. This is called microneurography. We insert very small needles inside the nerve, and then we count the number of action potentials. It's a research technique. Can we do it? Well, we can record the electrical activity, but we have no software to analyze it. And in fact, none of the vendors that make electrode myographs have the software to do microneurography. But sometimes you get the question that, can you do microneurography? Yes, as far as recordings are concerned, our amplifiers are capable of recording those small nerve action potentials. So these are the problems with using the routine nerve conduction methods or EMG methods to study small fibers. So therefore, we have got some slightly different methods of analysis. Again, I will look at what can be done with an EMG machine and nerve conduction type of protocol. We can study the response to pain by looking at what is called a cutaneous silent period. Just as an analogy, let's say you step on a thorn. What happens is that your foot is withdrawn. That's what we do in cutaneous silent period. We stimulate the nerve so that it is very painful. And then we look at a muscle response. And that test is called cutaneous silent period. We can do it on our EMG machines. In the new settings, we have a default setting available for them. And sometimes you will see it demonstrated in scientific meetings. But again, it's not a commonly performed procedure. It has got its own problems also. We can use evoked potential methods. We can stimulate using lasers, or there is what is known as contact heat, which is based on Peltier effect device. Note that the laser stimulator or the contact heat stimulator, these are external devices. They can be interfaced with our systems. So we can do the evoked potentials to study the small fibers. We have done this. We have demonstrated it in various workshops. So if somebody wants to do it, yes, our equipment is capable of performing these functions, but we don't have the stimulators. You have to get your own stimulators and then connect them through an interface cable, etc. So these are some of the techniques that are used in a kind of standard way, like analogous to nerve conduction. Now, the typical way the small fiber study is performed outside of an electrodiagnostic laboratory by non-electromyographers is by looking at the physiologic response of the body to different types of stimuli. And the kind of responses that we look for are change in blood pressure, or change in heart rate, or sweating. Obviously, they require different type of equipment. But heart rate is something that we can measure by using an EMG machine. So the electrodiagnostic testing done in small fiber neuropathies or in autonomic nervous system dysfunction is mainly based on analysis of the heart rate. So let's now focus on what methods are available on our electromyographs, what are their settings, how they are performed, and so forth. Let's begin with the parasympathetic testing. This is done by looking at heart rate variation with breathing. We usually think about heart rate being fixed, that my heart rate is 70 or 80. That's not correct. The heart rate is changing continuously with every heartbeat. And we can demonstrate it particularly with breathing. So this is the study of heart rate variation with breathing. Healthy individuals show variation in heart rate. In pathology, the heart rate changes much less. So high variation is normal, less variation is pathology. We can look at the change in heart rate by using what is called a Valsalva Maneuver. And we can also look at heart rate changes with posture. These are the three principal modalities that can be used. To record EKG, you can use any lead that will give you a high amplitude. If you go for an electrocardiogram study, they will put a lot of electrodes and maybe even make a 10 or 12 channel recording. But for our purposes, one channel is more than enough. In a laboratory, they probably will place the recording electrode on the chest. But when we are doing demonstrations, that's not possible for practical reasons. So what you can do is place your active or even electrode on the left wrist, where the median nerve is stimulated. Place the reference electrode on the right wrist, again, where the median nerve is stimulated. You don't have to be exactly on that side. You can be off by a few centimeters. It doesn't matter. And then the ground electrode or the E0 electrode is on the back of the hand. Here are the settings for the filters. I usually use a low frequency of 10 to 30 Hertz, high setting of 100 to 200 Hertz. You can change these settings. That's not a problem. If you increase the high frequency setting to 2 kilohertz or 5 kilohertz, you will get higher amplitude, but you will also get more noise. Keep in mind that we are not analyzing the waveform of the EKG. So you can change the filters any way which you want to get a good stable baseline. The notch filter is often not necessary. You adjust the gain as necessary. I usually find 100 to 500 microvolts works best. The sweep duration is 500 milliseconds per division for the programs that we are going to use. Obviously, you can record the signals at any sweep, but this is the setting that we are going to use, as it will become obvious when I show you the actual recordings. We use an amplitude trigger and we adjust the level as necessary. This is used to detect the QRS complexes. And we set a delay of 1 division. That's a standard part of amplitude, trigger, and delay module. And we typically record for 60 seconds. So if your sweep is 500 milliseconds per division, which is 5 seconds per sweep, we are going to record 12 sweeps. Here is a sample recording. Here is the ECG or the EKG. The red line is your amplitude trigger. Notice that our anatomy selected over here is vagus. Our sweep is 500 milliseconds per division, or a total of 5 seconds. Gain is 200 microvolts per division. My low frequency setting is 10 Hertz, high is 30 Hertz. Notice it's a very narrow band and it still gives you very good signals. And here are the 12 sweeps that are recorded one below another. The first QRS occurs at the first division by using an amplitude trigger. And notice that the subsequent QRS, they don't occur at the same position. This is what reflects the variability in the heart rate. If the heart rate didn't change, then all of these QRS complexes would line up against each other. Let's define some of the measurements. I'm showing you the EKG signal in the triggered mode. Here is the first QRS. Here is the second QRS complex. And the time interval between the two is called the R to R interval. So when you are performing analysis, you will find that some laboratories are referring to the heart rate variability. Other laboratories may be referring to the variation in the R to R interval. It's basically the same phenomenon, whether you are looking at rate or time, it's up to you. So in this case, for example, after recording several discharges, we find that the minimum interval is 761, maximum is 865, and a simple way of calculating the variability is the ratio. So 865 divided by 761, and you get a value of 1.13. It's a simple measurement, but in practice it can be quite difficult. Here is a recording from a healthy subject, and notice how the heart rate is changing. And here we have a lot of variability, here we have less variability. So if you look at the maximum to minimum over here, it can be quite different because of trends. Over here, we got a lot of variation. So in some equipment, they look at the respiratory cycle. So this is one breath. This is the next breath, the third. And they look at the maximum to minimum ratio, or the so-called E to I ratio. Exhalation, inhalation, E to I ratio in each breath, and then they take the average value. Over here, I'm just showing you the absolute maximum to absolute minimum value. The point I'm trying to make is that the heart rate can change, it can go up, it can go down. So measuring its variability is not a very easy task. And therefore, we will find that there are a lot of different measurements that have been postulated. We already talked about the maximum to minimum ratio. Another measurement is called the coefficient of variation, or COV. And one method is to take the difference between maximum and minimum divided by mean. You multiply it by 100 to get a percentage. So this is one definition. There is another definition of coefficient of variation. This is actually the correct definition. The definition described in statistics is this one. The definition indicated on the top is something that was invented in the EMG laboratory. Anyway, so we can calculate the coefficient of variation as standard deviation divided by mean. So although we are talking about COV, we have two different formulae. I'm going to come back to it again. We can calculate something called root mean square of successive differences. I will illustrate the calculation later. There is also something called triangular index. The triangular index is used mainly in long-term recordings. This is not for looking at variability over a short period of 1 minute. That's what we do in EMG laboratory. The triangular index is used when you are looking at variation over perhaps a day. So this is something that we don't use in our analysis. Now, going back to the definitions of COV, in the Viking software several years ago, the coefficient of variation was defined using this formula, maximum minus minimum divided by mean. And in the Synergy system, it used a different formula. So this caused a lot of confusion when we went to version 21 software, because Viking users who were familiar with this formula suddenly started using the second formula, and they got what they described as wrong results. So there was a period where we had this difficulty. If any of your customers have these issues, just explain to them the proper formulae. And in the recent software, we have made sure that we have included both formulae, so Viking and Synergy users can both be happy. Let's look at the calculations. So in this schematic, I have shown 7 successive intervals, the R2R intervals, 1000, 1100, etc., etc. We can find the maximum interval 1100, in this case indicated by green, minimum interval 900, and we can take the ratio 900 by 1100 and we get a ratio of 1.22. We can calculate the coefficient of variation, 1100 minus 900, maximum minus minimum, so that difference is 200, divided by the mean value 1007, and that's 19.9%. We can calculate the standard deviation of these intervals, that is 62, 62 divided by 1007, and express it as a percentage, 6.2. You can clearly see that the two definitions give us very different results. So we have to make sure that the instrument is set properly. We can calculate the RMS ST, and that is done as follows. Here are the successive intervals. We look at the difference between successive these RR complexes. So 1000 and 1100, so the difference is 100. 1100 and 1050, the difference is 50. We ignore the sign. So we look at the successive differences over here. We calculate the square of successive differences and then take its average value. And finally, we take its square root. So here are the intervals. Calculate the difference, square the difference, take the mean value, and calculate the square root. So root over here of the mean value of the square of successive differences. That's the way this formula is calculated, and in this case it is 91 milliseconds. Some of you who are familiar with single fiber EMG will easily recognize that the jitter calculation in neuromuscular transmission uses a formula which is also based on successive differences. Anyway, so we have a wide variety of formulae that are available for quantifying the variability of heart rate. So here is an example. This is a recording at rest. You can see the variation over here. You can perhaps recognize the effect of respiration as the rate goes up and down. But this variability is quite low. Here is the result table looking at rest. I will show it in a larger font. You can see range over mean. This is the same thing as maximum minus minimum divided by mean. So this is the old definition of coefficient of variation from Viking. This is the ratio of maximum to minimum R2R interval, the RMS ST that I just described, the coefficient of variation. This is the Synergy, old Synergy method of calculating variability using R2R interval. And then you can also have figures like minimum, maximum, etc. It's entirely up to the user to configure this. Now you will find there are two schools of laboratories. There are some that work using R2R interval. There are others that use the heart rate or beats per minute. So you can also configure the result table in a slightly different way. Here we are looking at minimum heart rate, maximum heart rate. You can also calculate their ratio, which is going to be the same as the R2R interval ratio. Some laboratories, for example, will look at the difference between minimum and maximum heart rate. So they don't go through this detailed calculation. And they would say, for example, if the difference between the minimum and maximum is more than 5 beats, then it's a normal study. If the difference between minimum and maximum is less than 5 beats, then they would say the variability is reduced. So it's entirely up to the user how they want to select it. You will notice over here that I have got two results. One is the measurement at resting, and one using 6 breaths a minute. Indeed, the variability depends on your rate of respiration. And it turns out that the variation is maximum when the breathing rate is 6 per minute. So in the software, we provide what is known as a metronome. You can see the function key over here. And this will show you this bar going up and down, helping the patient tell when to breathe in and to breathe out. So here is a 1-minute recording. There are 6 breaths. So you can see the cyclic variation over here. This is also called the sinus arrhythmia. And now our variability is much more compared to our previous recording. Once again, this is the variation at rest. Again, this is normal at rest. And then this is 6 breaths per minute. So with normal breathing, your variability is less. So many times, if you find that the variability is reduced or borderline, it's a standard practice to perform this paced breathing at 6 breaths a minute to see if we can bring out the heart rate variability. Now here is a question. Do you think this variability is normal? Let's look at the numerical data. The minimum, maximum, if you look at the variance, it is very high. The standard deviation is very high. The RMSST, these are really very high values. But high values can sometimes be abnormal too, because there is a normal range of measurements and there is a lower limit and upper limit. When variability is reduced, it is abnormal. But if we find very high variability, it could be because of a concomitant heart disease. If you look carefully over here, this is my heart rate variation, and you get a suddenly very short interval followed by a very long interval, and a short interval followed by a long interval. These are what are called ectopic beats. You can also see it in EKG. Here are 2 heartbeats that came in very quickly, and when you get such a short interval, it is always, I shouldn't say always, many times, followed by a very long interval. Here is another example, a short interval followed by a long interval. So these are called the ectopic beats. And if you have ectopic beats, now all for your calculations of variability are going to be normal. So you have to watch out for this. Ectopic beats will give very short and very long intervals. So if you see such a pattern, you immediately have to ask the patient. Actually, it's better to ask the patient beforehand if he or she has a concomitant heart condition. Now, in this particular case, we saw lots of ectopic beats, but sometimes patient may not know about it, and you may just get 1 ectopic beat. Again, that will change your ratio of maximum to minimum and so forth. So in those cases, we may have to remove the extreme values that occur in isolation. And in software, we can do this by right-clicking on that value. Now let's talk about the next test, which is called the Valsalva Maneuver. This may sound strange to you, but it was described by Dr. Valsalva from Italy in 17th century. And this is something that many of us have done in our life, where you just didn't know it was called Valsalva Maneuver. This is something that is used to clear your ears and sinuses. So if your sinuses are blocked or your ears are blocked, perhaps after a long flight, what you often do is perform a forced expiration. So you kind of close your lips and then you hold your nose and then you try to blow out. And that kind of releases the pressure in your sinus and clears air. Scientifically, this is called forced expiration at a fixed resistance. That's what's called a Valsalva maneuver. So you close your mouth tight by puffing cheeks and try to push the air through your mouth, and you can feel the pressure in your abdomen. This is what is called a Valsalva maneuver. We look at the ratio of maximum to minimum heart rate after performing this. So here is a recording. Once again, you can see EKG on the top over here. The horizontal line is our trigger. These are the triggered sweeps. Here is our triggering QRS. You can see the variability. And here is the graph. Time is on the x-axis, heart rate is on the y-axis, and this is the resting heart rate. You can see slump variation because of breathing, and this is where we instructed the patient to start the maneuver. We push the start maneuver button. You can see the function key. As soon as you hit it, it will put this red cursor indicating the time when the process was initiated. And when you begin the maneuver, you will see that now there is a steady increase in the heart rate. You have to keep the patient and encourage the patient to keep holding that pressure for about 10 to 15 seconds. It's pretty difficult to do it for more than 15 seconds, 1-5. And then you ask the patient to relax and breathe normally. And what will happen is that the heart rate will immediately drop. It will reach a low value within a few seconds, and then it will bounce back and come back to the resting state. So this is the Valsalva maneuver. Resting, this is during the maneuver, the heart rate goes up. As soon as the maneuver is finished, it goes down, and then it bounces back and back to the baseline. So what we do is to calculate the ratio of maximum to minimum heart rate, and that is indicated as VR in the result table. We typically like to do it about 3 times. Sometimes the first trial itself is excellent. You may not want to do 3 trials, but the general convention is to do 3 trials, and some people will use the maximum value, some of them will use the average value. All of the issues that are indicated with ectopic beats also apply to Valsalva maneuver, because that is inherent in the EKG recording. So if you find some very high or very low intervals in the Valsalva maneuver, they will again indicate to you that there is probably another concomitant heart condition. And if it occurs in isolation, you can again delete the points. So that's what's called a Valsalva maneuver. There are other types of stimuli that can be used. One is, for example, asking the patient to stand up from supine position. Supine means the patient is lying down. What happens is that when you stand up, all of a sudden there is a shift in the blood. It is going to move to extremities in your feet, and that affects the amount of blood that is coming back to the heart, and it affects the heart rate. So that's the relationship between the blood circulation, volume, and heart rate and other things. So what you have is the patient lying down comfortably, record the ECG, look at the heart rate, and then you ask the patient to stand up. And then you measure the heart rate at the 15th second and 30th second, and you take their ratio. Some like to measure the 15th beat and the 30th beat after standing up. And some find that this minimum or maximum doesn't actually occur precisely at 15th. So they will look within the first 30 to 40 seconds and look at the maximum to minimum interval or the maximum to minimum heart rate after the change in posture. So this is what is called a 30-15 ratio test. If the patient has got electrodes on their chest or on their periphery, and if they try to get up, you are going to get EMG artifact. So it doesn't actually work very easily if the patient has to stand up by themselves. It works much better by using a tilt table. So the patient is lying on the table, they are strapped down securely, and when they activate the tilt, within a second or so, the patient goes from a lying position to a vertical position. There are no artifacts and other things. So tilt table is something that we don't supply. Many laboratories may have it, but it's an extra component that you need to perform this procedure. Just as an example, here is a study that I did on myself. So I was resting over here, and notice my heart rate went up as soon as I tried to get up. So this is where I stood up. I pushed the button, record the maneuver, so that's why we have the red line. And then you find that the heart rate went down upon standing up, reached a low value, and then reached again a high value. So the ratio of maximum to minimum is the 30 to 15 over here. Now you have to be very careful with the software. What the software does, it looks at the maximum to minimum after this cursor, and the maximum value is immediately after the cursor. So the calculation is actually based on the intervals or the rate over here, not from here. As far as the minimum is concerned, it's fine. So whenever you perform such procedures, you may have to change the position of the cursor manually. So I'm going to click on the cursor and then drag it over here, because this is where I would like to start my calculation. And now the system will look at the maximum to minimum after the red line and give you the correct results. So these are some of the things that you have to use in your tests. Just as you remove the ectopic beads, you may have to change the position of this cursor. You can have other stimuli. One would be exactly opposite of standing. You can have a patient standing up and then you can ask them to lie down. Or you can ask them to squat. Again, when you squat, there is a shift in your blood volume in the body that will affect your circulation. Again, these are something that are may not be very easy for some patients to get into a squatting position. There could be artifacts in EKG and so forth. You can have other stimuli, for example, applying a cold pack on the face, and that is going to change your heart rate. We have often seen in movies when somebody faints, they splash some cold water on face to revive them. So again, it's a kind of stimulus to change your body homeostasis, to kind of jumpstart it, if you want to call it. So these are the different types of stimuli, but the most common ones are the Valsalva ratio and the paced breathing. Now, along with all of these tests, we need reference values. Here is a table that I'm showing from a publication by Drs. Barron and Ewing. I will give you the reference later. Notice that the normative data very much depend upon age. So you have to have age-matched reference values. They depend upon the measurement, so coefficient of variation, and whether you are doing the study at rest or you are doing during deep breathing. So reference values are important. The reference values may also depend on medication. I shouldn't say the reference values, the measurements in a patient can also change with medication. So different physicians may give specific instructions to the patients regarding intake of their medication. Certainly, you want to avoid any kind of stimulus like strong espresso or something before the test is certainly not recommended. But I'm not going to go into the details of how to manage the patient in order to get them ready for the procedure. Some studies also report that the heart rate variability depends on the body mass index and so forth. Anyway, let us now move to another topic. I talked about changes in the heart rate. I had also mentioned changes in the blood pressure as one of the physiologic response. There are equipment that are available to monitor blood pressure and do the same function. And we can also look at the sweating or the Sudomotor testing. So we have dedicated equipment that can measure the generation of sweat in response to various stimuli. They are often called the quantitative Sudomotor axon reflex test, QSART. Again, this is a dedicated test that cannot be performed by using your electromyograph. But from time to time, you may get questions about whether the machine can do it. No, this is a very specialized equipment for testing. The test procedure itself can take quite some time, 1 to 2 hours. Sometimes it may take 3 hours. Note that you are making very fine measurements. You are collecting and measuring microliters of sweat produced by the patient. So they require a lot of attention. And because of all the equipment, all the other stimulation thing that you may have to use, it can be a little bit expensive compared to the electrodiagnostic testing that I just described. But something related to Sudomotor is the sympathetic skin response. Sympathetic skin response is the electrodermal activity from the sweat glands. This response is also called the galvanic skin response. If you are into watching movies related to investigations, the criminal investigations, you often find them taking a lie detector test. And one of the inputs to that lie detector test, when you see those pens moving up and down, is actually the galvanic skin response. Again, it is related to how your body reacts by producing sweat to various types of questions, questions that make you relaxed or questions that make you tense and so forth. Anyway, I just wanted to show you the equivalence of whatever testing that we do to things that we see in our real life. So to record the SSR, we can do this in upper limb by putting the active electrode in the mid palm, the reference electrode on a digit. We could do this in a lower limb where the active electrode is on the sole, the reference electrode is on the dorsum of the foot. And then we stimulate the opposite limb using an intensity level that is painful, because we want to stimulate these small fibers to study their functions. So you really want to cause a little bit of pain. And usually if you were to use a stimulus intensity that is similar to that used in supramaximal stimulation in nerve conduction study, that works quite well. You could stimulate on the same limb, but sometimes that can produce movement artifacts. So the recommendation is to do it on the opposite limb. You can do it simultaneously in upper arms, lower arms. It entirely depends upon the number of channels. So you could do an SSR in upper and lower limbs bilaterally at the same time. That's quite okay. The filter settings, low frequency is 0.1 to 0.2 hertz, and that's the most important setting in this test. If you increase your low frequency setting to 2 hertz, you are practically going to lose the response. At 1 hertz, you may get some response, but ideally, the frequency should be as low as possible. 0.1 to 0.2 works nice. The high frequency can be 100 to 200 hertz. You could use higher setting, but that will give you more noise and it may give you slightly more amplitude. Notch filter should not be necessary, but if you have to use it, you have to use it. The gain is 100 to 500 microvolts per division, adjust as necessary. And the sweep is 500 milliseconds per division. Sometimes we use 1000 milliseconds per division. So you are looking at an epoch of 5 to 10 seconds. Keep in mind that these responses are conducted at very slow speed. So the latencies of these responses are not milliseconds, they are of the order of seconds. So typically a response in the upper limb will appear at about 1.3 seconds. In the lower limb, it will appear at about 2.5 seconds. So you need a long sweep, something like 5 seconds to 10 seconds, to detect this response. So here is an SSR. Here is the first stimulus. You will notice the baseline, and here is the response. It doesn't have any specific shape. We don't analyze the morphology. We may measure its onset latency, and we may measure its peak-to-peak amplitude. Now, one of the things that you have to be aware of is the phenomenon called habituation. So when the same subject was stimulated again, we did get a response, but notice that the amplitude went down from 1.2 to 0.5. And with the next response, the amplitude went down even further. This is called habituation. So if you try to do this test too many times, you may stop getting the response. You have to be careful. If you don't get a response, you can try other stimulus modalities. For example, you can make a loud sound by clapping, or you can ask the patient to take a quick gasp or sniff, and that produces a sympathetic skin response shown on the top trace over here. And this is in response to the cough. The problem is that with these methods, you really cannot measure the latency. The SSR is reported in two different ways. There are some laboratories that will measure the latency and or amplitude, and they may have normative data for it. But by and large, I find most laboratories will describe presence or absence of a response. If the response is present, that means your test is normal. If the response is absent, then you must try different modalities of stimulation to confirm that the response is truly absent. So in conclusion, autonomic testing can be done using an electrodiagnostic system like the Quest, Ultra Pro, Viking EDX, Synergy EDX, Keypoint. It is relatively easy. It is non-invasive. You are using surface recordings. It assesses the sympathetic and parasympathetic function. Keep in mind that the reference values depend on age. They are affected by the demographics. Habituation can occur. And most importantly, when you are going to use ECG recordings or EKG recordings, you have to ask the patient if he or she has a concomitant heart disease. By using these simple tests, we can study the autonomic function in patients with different types of pathology, such as polyneuropathies, stroke, and so forth. And in this way, it can help us give a better appreciation of the involvement of autonomic nervous system in these patients and help their physicians to better manage them. Here are two good references. Here's a paper by Dr. Stolberg, which describes the measurement of heart rate variability and some normative data. Here is another article by Dr. Barron and Ewing. I showed you the reference values from their publications, and these are actually the guidelines to study the heart rate variability.